So good morning, everyone. Welcome to this webinar, which is pertaining to discussion of important questions for MRCOG 1. Now, why they are important is they are based on the theme of questions which were asked in the last exam. I'm not saying these are the exact questions, but these are the themes. And these, if you do the syllabus or you do the topics based on these themes, there's a high likelihood that you will pass this exam. So I would recommend all of you to go through these topics in depth. So for example, if there is a topic discussing to dental nerve, then you must go through the entire topic in depth because there might be any question pertaining to that. And not just the question which we are talking in the webinar today. Also, I would request all of you to make it interactive and please put the answers of the questions in the chat, because that way it'll be helpful for me also, it'll be helpful for you also. So I think I'll start with the webinar. So starting with the first question, a woman multipara at 36 weeks of gestation presents with complaints of reduced fetal movement twice within the past 24 hours. Upon ultrasound examination, it was found that the fetus was in an extended breech presentation. What would be the appropriate management strategy for this patient? A, it could be antepartum cardiotopography monitoring twice daily for 7 days, external cephalic version followed by immediate induction of labor, serial ultrasound examination every 72 hours to monitor fetal well-being, and position and plan for cesarean section if indicated, immediate induction of labor, or E, implementation of pelvic tilt exercises and positional changes under supervision to encourage fetal movement and attempt to facilitate spontaneous repositioning of the fetus. So what do you think should be the correct answer in this case? Please answer on chat. So yes, option is C, which is serial ultrasound examination every 72 hours. And why do you think this is required? Why not any other option? Why not CTG or why not ECV? CTG because this will check only the fetal well-being. And you also want to check the fetal position because you want to take a decision whether you want to go ahead with cesarean or you want to stay with normal vaginal delivery. So ultrasound becomes important in this case. ECV is not usually done at around 36 weeks. ECV is usually done around 37 weeks. Why is it not done before 37 weeks? Any answers? Because there could be a risk of preterm delivery or preterm labor. So ECV is not done prior to 37 weeks. And after 37 weeks, if you do it, then the process of ECV may be difficult because the baby might be, if any distress we can take. But yes, you need to find out. There's somebody saying if any distress we can take for cesarean. Yes, if there is a distress on ultrasound, then you can take. If you see liquor is reduced or you see there is some other feature of distress, you can take for an immediate cesarean section with an ultrasound because you know breech presentation will be difficult to deliver vaginally. So coming to the next question, a 30-year-old woman has been experiencing debilitating bladder pain that significantly affects her quality of life. Despite adhering to conservative management strategies, including lifestyle modifications and oral analgesics, she continues to suffer from persistent symptoms. What is the appropriate next step in her management? So what do you think is the diagnosis in this case? Yes, this is a bladder pain syndrome. And bladder pain syndrome is an important topic from perspective of MRCOG exam. So what does this comprise of? This is a triad. Triad of what? There is bladder pain, there is bladder pressure, and there is bladder discomfort. And along with this, there is presence of some urinary symptom, which could be increased frequency, urgency, nocturia, or they could be bladder filling pain. So why I'm talking in depth about bladder pain syndrome, also known as interstitial cystitis, is because there can be a complete question pertaining to this, and this topic is important. For part 1 also, part 2 also. Part 2, you can get a complete EMQ also on bladder pain syndrome. And there is a characteristic feature which you find on cystoscopy in bladder pain syndrome. What is that typical feature? Can somebody tell me? There are presence of pinpoint petechial hemorrhages. And these are known as glomerulations. And this is a typical finding which is present in cases of bladder pain syndrome. And there could be a picture-based question or an image-based question where they may give you cystoscopy picture showing these petechial hemorrhages, and they may ask you what condition this is. And how do you go about treating bladder pain syndrome? The first line of management is basically lifestyle modifications. So what kind of lifestyle modifications can you follow? You can follow stress management. You can make changes in the patient's diet. So the dietary changes basically include avoiding caffeine, avoiding alcohol, and avoiding acidic beverages or acidic food. Stress management. So this is the first line of management. The second line of management comprises of intake of cimetidine or amitriptyline. And third line of management, if this doesn't work, cimetidine and amitriptyline, what is the third line of management which you can go for in these cases? Third line of management is intravesical therapy with hyaluronic acid or lidocaine or Botox. So if we come back to the question, so now what do you think is the answer? She was not responding to lifestyle modifications. So what should be the next step of management in her case? Yes, administration of intravesical instillation with bladder instillation therapy. This could be with hyaluronic acid, or it could be lidocaine, or it could be Botox. So coming to the next question, a 32-year-old woman presents to the hospital with a history of missed miscarriage confirmed by ultrasound. What is the optimal management strategy in this case? So there is a history of missed miscarriage, and what is the optimal management strategy? A, initiation of medical management with misoprostol to induce miscarriage, recommending surgical intervention with dilatation and curettage to remove retained products of conception, offering continued expectant management with close monitoring and follow-up ultrasound assessments, referral for counseling and support services to help the patient cope with loss. Or E, discussion of future fertility consideration and contraceptive options. So what should be the answer? Yes, it should be A, because rather than going for any surgical intervention, it is better that you go with medical intervention in form of misoprostol to induce the miscarriage in this case. Coming to the next question, what is the risk of venous thromboembolism after 5 years of hormone replacement therapy? So is there any risk of VTE after HRT? So as per the WHI or the Women Health Initiative study and the Million Women study, it has been shown that increased duration of HRT, that is more than 5 years, could be associated with increased risk of VTE. So if it is 5 years, the risk is there. If it is 10 years, the risk increases further. If it is 15 years of HRT intake, the risk becomes even higher. So it is directly proportional to the duration of HRT. So what should be the option in this case? Yes, it is C, because you need to monitor her also for signs of venous thromboembolism. A pregnant woman who suffered a crush injury to her spinal cord in adolescence is now in the last trimester of her pregnancy at 36 weeks. She presents with worsening back pain, which is not alleviated by oral analgesics. The pain has become severe, requiring the use of crutches and wheelchair for mobility. What is the most appropriate management plan for this patient? So crush injury to her spinal cord, and now she is in severe pain, and also there is a severe loss of mobility which is occurring. So what should be the management plan in this case? A, admit her for rest and observation. Refer the patient to orthopedic for further evaluation and management. Prescribe oral opioids for pain relief. Offer induction of labor to alleviate symptoms and deliver the baby. Perform spinal fusion surgery to address the worsening back pain during pregnancy. So when you encounter such patients in your ward, what do you do? What is the first thing we do in such cases? Don't we call the orthopedician? Orthopedics referral is important because she's not, you can prescribe her oral analgesics, but she is not responding to that also. So obviously, if some intervention needs to be done, only an orthopedic surgeon would be able to recommend it or go ahead with it. So it is important to take an orthopedic consultation in this case. Okay, because in the exam, this is another tip I want to give all of you. When you address a question, think of your ward round or think of your normal scenario. What do you do in an OPD, or what will you do when when you encounter such a patient? Because that is what they are testing, that how do you routinely you will be able to deal with the patients or not. So next question, what antihypertensive medication is preferred for postpartum asthmatic patients? So if the patient is having asthma, what is the antihypertensive medication which you should give? So nifedipine is a calcium channel blocker. And does it affect your airways? It does not. So maybe, but you should also look at the other options. In the exam, try to look at all the options. If you feel A is correct, then it should not be that you just don't look at B, C, D, E. You also look at that, because sometimes the answer could be A plus C or A plus B or something like that. So make sure you look at all the options, you rule out all the options, then you choose the correct option. So propranolol, this is a beta blocker. Obviously, this will cause bronchoconstriction. Lisinopril, ACE inhibitor, this will also cause bronchoconstriction and it may result in cough. Furosemide, a diuretic. Terazosin, again, an alpha blocker. So obviously the treatment of choice in this case is calcium channel blocker or the medicine nifedipine, because this will not affect the airways. So coming to the next question, a 36-year-old woman who has undergone type 3 female genital mutilation. Again, there will be surely a question pertaining to female genital mutilation. So make sure you remember the classes, the classification, and everything about FGM, because for sure there'll be one question which will be pertaining to FGM. So she delivers her baby via cesarean section. However, de-infibulation was not performed at the time of delivery. What should be the course of action here? So she has type 3 female genital mutilation. What does this mean? That means the vaginal introitus has been stitched and the introital opening is narrowed out quite a lot. And she had a cesarean section. So obviously, at that time, de-infibulation was not done. What is de-infibulation? That means you're cutting the scar tissue. And as a result, you're opening the vaginal opening. And infibulation or stitching the vaginal introitus is actually illegal as per the UK laws. And if you encounter such a patient, then what is important? That you go ahead with de-infibulation. And this will also help in her recovery, post-op recovery, because it'll facilitate the drainage of lochia and other discharge, and it'll be useful for her. So you should offer her de-infibulation in the clinic before she goes with discharge. because this allows for timely intervention. It ensures women's well-being and it helps in reducing the risk of complications associated with FGM. It will help in restoration of vaginal anatomy, and it will also help her in her sexual intercourse, may alleviate physical and psychological discomfort which is associated with FGM. What is the recommended pharmacological treatment for postpartum hyperthyroidism, considering its safety profile for breastfeeding mothers and newborn? So for postpartum hyperthyroidism, what is the medication of choice which should be given? Yes, PTU or propylthiouracil, because the transplacental passage of this drug is also very low, as well as it is also not secreted in the breast milk. So minimal transplacental transfer and also minimal secretion in the breast milk. That is why you should prefer PTU. In cases of lichen sclerosis unresponsive to topical steroid therapy, what is the preferred sequential approach considering the patient's clinical response and the need for precise diagnosis? So a patient of lichen sclerosis, she's not responding to topical steroids. What should you do now? In this case, you should go ahead with a biopsy for histopathological evaluation. There is no underlying malignancy, because normally lichen sclerosis, it should respond to topical steroid therapy, but before undertaking some other treatment, if it is not working to topical steroids, you should be sure that this is something which is lichen sclerosis only, it is not something else. In study investigation, the association between umbilical artery Doppler and development of preeclampsia based on confounding factors like BMI, age, parity, which statistical method is more suitable for analysis? Somebody is saying before diagnosis wasn't biopsy done. If the question would have mentioned it if biopsy was done. So if they are not mentioning, that means it was just a clinical diagnosis, because they would have then mentioned it that in a patient with lichen sclerosis, which was confirmed on biopsy. Okay, Sukriti. So coming to this question, investigating the association between umbilical artery. So you have one dependent variable here, which is umbilical artery Doppler, and you have to investigate its association with various factors like BMI, age, parity. So what is the statistical method which should be most suitable in this case? Now, if you talk about correlation, then Pearson's correlation coefficient, this is between two variables. Spearman's rank correlation coefficient is also between two variables. And this is a parametric test, and this is a non-parametric test, because this itself could be a question. Analysis of variance or ANOVA is the comparison of means of two groups. Here you don't have groups. And linear mixed effect modeling is basically for data which is in form of clusters or in form of a hierarchical data, which is also not in this case. So it is obviously multiple regression analysis. Multiple regression analysis is basically an association between a dependent variable with several independent variables. So in this case, the dependent variable is umbilical artery Doppler, and the various independent variables with which its association has to be tested are BMI, age, parity. So obviously, this becomes the answer. Coming to the next question, which secretion found in the eyes and tears protects them from bacteria and other pathogens? So again, a tricky question. Every time in the part 1 exam, they'll have one or two questions which will be completely off the topic. Like this one is on eyes, tears, and tear film. So don't worry about them. There'll be in every exam, there will be 2-3 questions about like that. Give your best, whatever you think, because it's not possible for anyone to know everything. So if you do encounter such questions where you feel you don't know, don't get disheartened. You proceed with other questions. Because in one exam, they had asked something about Horner's syndrome, and there were 2-3 questions pertaining to it. In this, they've asked about this tear. Again, this is nothing to do with obstetrics and gynecology, but then you can't help it. Okay, so just to explain what there is something, there are tears, and I also have something called a tear film, which will form a film over the conjunctiva and it'll protect it. So when you come to the question, the tear itself is different and the tear film is different. The tear will contain various substances like you have mentioned in your answers, also lysozyme, lactoferrin, lipocalin, secretory immunoglobulins. But a tear film, on the other hand, because you may have a question pertaining to that also, tear film is basically composed of 3 layers. There's an outer lipid layer. There's an inner or a middle aqueous layer. And there's an inner layer which is composed of mucin. This is produced by goblet cells. And this is produced by the meibomian glands, or this is meibum. So if you come to the question, it cannot be mucus, it cannot be immunoglobulin A, it cannot be meibium, because meibium and mucus, they form part of the tear film and not of tears. So in case where father is Rh positive and mother is Rh negative, how does anti-D immunoglobulin prevent Rh sensitization in the mother? So what is happening in Rh isoimmunization? So in Rh isoimmunization, what is happening is, so the mother is Rh negative and father is Rh positive. So there's a high likelihood that the baby could also be Rh positive. Now, normally what happens in an Rh positive person, there are this Rh antigen is present. Whereas in a Rh negative patient, in an Rh negative person, there is no antigen and there is no antibody. But what happens is that if they are exposed to the Rh antigen, then the antibodies, they begin to form. But otherwise, there is no antibodies in this case. Now, what happens is that baby born is Rh positive. Now, there could be some feto-maternal leak, and as a result, some Rh positive cells from the baby may pass into the mother's bloodstream, and this may induce the formation of antibodies. And this is what is the Rh sensitization, which is occurring. And these antibodies, they may go and then travel to the baby and destroy the fetal red cells, resulting in hemolytic anemia. But when you give anti-D immunoglobulin, what happens is that these Rh positive cells are blocked, or these are destroyed by these anti-D immunoglobulins. And as a result, these Rh positive cells, they cannot induce the formation of antibodies. And as a result, the antibodies which are formed, they will not travel to the baby and they will not result in hemolytic anemia. So now everybody is answering that it prevents the attachment of Rh antigen. So the answer is this, that it targets and destroys any fetal Rh positive red cells in the mother's bloodstream, and as a result, antibodies cannot be formed in the mother's bloodstream.